Thank you everyone for coming, and this is going to be recorded for our website as well. Thank you, Dr. Patni, for coming and doing this talk. Do you want to first introduce yourself to whoever is on the call?
Sure. Thank you so much for having me here. I am very happy to talk about what I'm really passionate about, which is lipodystrophy and patients with lipodystrophy. So, extremely happy to be here and trying to see if there's more awareness I can spread about this disease. So, I am Nivedita Patni. I'm an associate professor of pediatrics at UT Southwestern Dallas. I see a lot of kids with rare lipid disorders and lipodystrophy in my practice, and I'm hoping before I retire someday I can make life better for them. So today I'm going to be talking about challenges in diagnosing lipodystrophy syndromes in children. I do have some disclosures. I've done speaking for Chiesi. So I want to start my talk by mentioning that children are not miniature adults. They have a very specific physical and cognitive development throughout the 18 years that we call childhood. From 0 to 18 in my mind is considered childhood, and there's an ongoing process in those years. The growth and metabolic processes undergo significant changes around the puberty. So there's infancy, there's preschool years, there's regular childhood years, and then the puberty brings a whole new process as well. And they have very distinct nutritional needs, again, through all these phases, which differ a lot from adults. In addition, they have very unique emotional and mental health needs as well. So, quickly about lipodystrophy, it can be divided into genetic or acquired, and then based on the distribution of subcutaneous fat loss, there are four subdivisions. So, genetic could be congenital generalized or uh, familial partial lipodystrophy, or acquired could be acquired generalized or acquired partial lipodystrophy. So I'm going to talk first about familial partial lipodystrophy because this is by far the most common lipodystrophy that is diagnosed and that is prevalent. Interestingly, clinical features of familial partial lipodystrophy do not present till around puberty age. So the kids would have a normal fat distribution in childhood. And then around the age of puberty, they start having gradual loss of subcutaneous fat pretty much just from the extremities, in addition to some gain of the fat around the face, neck, and intra-abdominal regions. They also have marked insulin resistance, dyslipidemia, primarily hypertriglyceridemia, which leads to early diabetes and hepatic steatosis, and then the later age atherosclerotic vascular disease or ASCVD. So this was one of my patients. She was diagnosed because of the family history. And we see here that she's around 6 in this photo. She had pretty normal subcutaneous fat distribution. Until around age, we didn't see much, and then she started losing around the gluteal area. So this is an MRI, which kind of emphasizes what I've been trying to say. So the first uh, A and D, these side are of FPLD child. The second slot is for an FPLD adult. And the third one is showing normal. And you see how the head, neck, and the thigh region in a child pretty much mimics a normal. But as they keep growing older, there is deposition in the chin and the neck area, along with the loss in the thigh area. So we did look into chronology and to see if there's a specific age in which we would see changes happening. So the background for these graphs is NHANES data. So the norms are based on the NHANES data. The solid circles are for females with classic lamin mutations that cause FPLD, and the empty ones are atypical lamin variants. The square on the right side are for boys. There are not very many boys diagnosis. It's more prevalent in females, which again is a discussion for another day. With being an autosomal dominant disorder, why is there discrepancy? But we definitely see it more in girls. So here, the green triangle is showing the age of thelarchy, and the red triangle is showing the age of menarche. And we see that in most of the classic lamin variants, their subacute loss of the triceps is happening much before the thelarchy and menarche, versus an atypical maybe if you see that yeah, it is happening a little later. So maybe puberty is not the trigger, maybe it's something else that we still haven't quite figured out. This is a DEXA image of the same patients. And so you see how the lower extremity fat loss by DEXA is already happening before the thelarchy in females. And males, we had such few numbers that I don't think it is an accurate description, and we just don't have enough data right now to see the onset in males. And this is the other main clinical picture that we see, right? Majority of the females are developing high triglyceride pretty early on. So if you notice here, it's clear that after 12, their triglycerides are already starting to trend pretty much high. Now, these units are milligrams per deciliter, which is not the SI, but it is the units that we use in US mostly. And it ideally should be less than 100 or 150 in most people. And they are going as high as thousands in some of these kids with with the FPLD variants. So this is the pattern of fat loss, and I really like this depiction because it's showing how and where the fat loss usually happens, where it is probable, and there are areas that are fat sparing or even fat accumulation happening. So it's a pretty good depiction of what we are looking for. So I want to come back to the challenges here to see that the missed diagnosis is usually because there's no observable phenotypic changes or actual examination changes in girls that are less than 8. In males, it usually doesn't happen until adolescence. The metabolic changes are not happening before 12, but it's very difficult to even pick them up if you're not doing a full exam in somebody who's getting metabolic features at 12. And it can often be misdiagnosed as Cushing's syndrome because of the fat deposition that's happening pretty similar to Cushing's syndrome. So, diagnosing patients with this specific subtype of lipodystrophy is very difficult unless we are doing cascade screening approach, which means if there is a known family member, to screen other family members because it's an autosomal dominant inheritance, and so we can help pick up the diagnosis if we know a family member with this disease. Now let's talk about the second most common subtype of lipodystrophy called congenital generalized lipodystrophy. So this was again one of my patients. If you look at her, she already has minimal subcutaneous fat, and she was noticed to have minimal subcutaneous fat pretty much soon after birth. So there's a near total lack and extreme muscularity present at birth or soon thereafter. They also have very prominent veins because of the loss of subcute fat. So the veins are prominent. They have voracious appetite, accelerated growth, and advanced bone age, and some of them can have bone cysts as well. And there's umbilical prominence due to severe organomegaly, which is the hepatomegaly or splenomegaly, which means the liver and spleen are enlarged that causes that umbilical to be prominent. They can have very early onset darkening of the skin around the neck and underarms called acanthosis nigricans. And the girls can have some clitoromegaly and hirsutism features as well. So this is again the depiction of the fat loss. You see the yellows are the areas of fat loss, and it's pretty much diffuse. Now, the blue areas, it is possible because there are subtypes within this as well. And so there is one subtype in which the scalp and the palms and the soles loses too, but the others might not lose it. Now, the challenge in diagnosis of congenital generalized lipodystrophy is that even though the onset or the presentation is happening soon after birth, the diagnosis is getting missed till very late. And this is some data from Turkey and Spain that's showing it. So on the left, you see in Turkey how the age of diagnosis was about 16 and the age of first admission was 12, even though the probably presentation of onset was at birth. And this one has majority of kids with CGL, the congenital ones, 93% had CGL. And then the data on the right is from Spain, and that's also showing pretty similar how the age of diagnosis is so different and generalized, even though the onset is pretty early. And the other worry about these kids is that the metabolic features are presenting extremely early. So again, left is the Turkey data, right is the data from Spain showing the diabetes and high triglyceride is presenting pretty much around the 10 years age in most of these kids. This is a subtype which I'm not going to go into more details, but it is much rarer than the type 1 and 2. Type 3 is the rarest, and type 4 is also a handful of kids that have been diagnosed. And these kids would also present with diabetes pretty early on, but they have very severe cardiac arrhythmia that's leading to high mortality in their 20s and 30s, and maybe even earlier. So the challenges in this specific subtype or the congenital generalized lipodystrophy is that although the phenotype or the features are manifesting soon after birth, the onset or severity of metabolic complications are serving as principal motivating factor for the referral of patients to centers for diagnosis, continued care, and monitoring. This is happening again around 10 or 12 years, even though they've been living with this for the first decade of life. So if we look into patient perspective, and we did a study which gathered information about how patients feel about this and patients are dealing with it, the primary concern about the quality of life among the adolescents was pertaining to their physical appearance and emotional well-being, and not knowing what they have for all these years brings it out a lot more. Unfortunately, at present, there are no medical therapies that can effectively normalize body fat distribution. So, again, getting a diagnosis later in life, even though it has been there and not able to fix it, is a pretty stressful event. And also, there's lifelong medical management for the secondary metabolic factors like diabetes, high triglycerides, fatty liver, as there is no specific cure for it to reverse anything at this point yet. Let's come to the third subtype, which is acquired lipodystrophy, which is less prevalent than the other two that I said at this point. But in my mind, it is less prevalent more because of missed diagnosis than anything, because I feel there's a lot of acquired generalized lipodystrophy out there that is not getting diagnosed. That's why, again, one of the reasons that I'm doing this talk. So, acquired generalized lipodystrophy is seen more in females than male by a ratio of 3:1. It is usually presenting before adolescence with progressive loss of fat affecting the whole body, including the palms and soles. So, the severity can be a little more severe than the congenital version. Some fat accumulation can appear in the face, neck, or axillae, but it's usually pretty diffuse. And these are associated with severe and frequent metabolic complications, the ones that we've been discussing through the other subtypes as well. So again, I'm going to show this image because it's a very nice depiction of how the spread is. Now, if you just have a glimpse of it, it might feel similar to the partial because the extremities are losing and the trunk is a probable, but there is no extra deposition as much as the familial partial hair. They do lose or they would not lose, but they wouldn't have as much deposition as the partial ones. There are three subtypes, and I want to go over the details of the photo. This was the first published case by Mr. and Dr. Garg, which kind of showed the progression of the first subtype or the paniculitis variety. So this little kid is 4.5 months old when he developed a paniculitis, which is like a subcutaneous fat loss in one localized region on the cheek, around 4.5 months. And then you see around 6 months, it becomes more progressive. There's a lot more subcutaneous fat loss around the face. By 10, he's lost all the subcutaneous fat in the face. And so it is quite rapidly progressive. I have a few kids with this subtype, and it can start anywhere in the body. It doesn't have to be face. One of the kids had it back. One of my kids had it in the legs. And it just starts as one big dimple, and it slowly spreads, then becomes generalized fat loss. The second subtype is the autoimmune variety, and this one is definitely more common than the other subtype. And this one is usually associated with juvenile dermatomyositis, Sjogren's, hepatitis, Hashimoto's, or juvenile rheumatoid arthritis. And this is the diagnosis I feel is missed the most because a lot of kids with autoimmune disorders require immunomodulators, therapies, chronic steroids, and the phenotype that is apparent at the during the therapy or at the end of the therapy somehow is contributed to the therapy rather than it being a lipodystrophy. because I have a lot of kids that were on chronic steroids for so long. And so this pattern of fat loss that we are seeing can happen with chronic steroid use too. And so it was always thought that they are looking like this because they received steroids for 4 months, 5 months. But the steroid phenotype is usually reversible once the therapy is stopped. But with the lipodystrophy, it stays like this. So if you have somebody you see 4 months after end of steroid therapy or 3 months, and they're progressively looking like they have subacute fat loss in the extremities or generalized, then they probably have acquired generalized lipodystrophy. And type 3, like most other diseases, is we still don't know. We're still trying to figure it out and work out why it is happening. So it's like that unanswered question that we want to know the answer to. So the challenges in acquired generalized primarily is misdiagnosis, as I've been saying. So a lot of kids, they are thought to have malnutrition. They're thought to have anorexia, thyrotoxicosis. So thyrotoxicosis commonly is an autoimmune disease. So you could have multiple autoimmune pictures running together, and so that happens a lot too. Chronic steroid use is what I was just mentioning. A lot of kids just feel like the phenotype is because of that. Severe uncontrolled type 1 or type 2 diabetes can cause marked weight loss due to extreme hyperglycemia and glucosuria, and that could be confused as the cause for subacute fat loss as well. And hypothalamic syndrome, cancer cachexia can be diffuse too. And again, talk for another day that how some of these kids can cause acquired generalized lipodystrophy as well. And last but not the least is the acquired partial lipodystrophy. So this one is not as common as the others, but more again in females than males. So there's 4:1 distribution, more in females than females and males. It usually begins in childhood or adolescence, and this one has a very classic fat loss distribution. So it does start on the face and then progressively affects the neck, shoulders, arms, and trunk. So it's a craniocaudal fat loss. Fat accumulation appears in the hips, buttocks, and legs. But the metabolic complications are very rare in this. So in that way, this is much different from others. This depiction is showing how you see the fat loss is happening only in the upper parts, not as much in the lower parts. Uh, the specific features for this specific subtype is the presence of C3 nephritic factor, low serum complement levels, and about 20% of these patients have membranoproliferative glomerulonephritis. So the complications are much different from the other three we have seen. They have more kidney-related and complement-related disorder than metabolic issues. So the challenges in this specific subtype is that it is a very heterogeneous presentation and it has a milder obvious features because a lot of people, the face is thin, but the other body looks okay. So it is very easily missed. And if you have not seen any kid with acquired partial before, then it's very difficult for you to notice it. They also have milder metabolic phenotypes. What's interesting and what needs to be looked into, and it's very new, is that there are some cases reported in children with leukemia, graft versus host disease, and hematopoietic stem cell transplant that are coming up with this phenotype. So there's not much known about these specific subtypes, and I feel we really need to learn more, know more as to what is causing this. And again, the phenotype and biochemical monitoring is still not part of the long-term follow-up for these patients. So this is an upcoming thing that I think we need to look into. So in summary, uh, uh, the main concern is recognition challenge. I really feel that these syndromes and disorders are frequently unrecognized. First, due to they are very rare. Second, because there is so much variability in how the appearance is, which causes a lot of diagnostic delays and treatment delays. So treatment, I'm sure, is going to be covered in another Lunch and Learn, and you guys should stay tuned for it. But there is a lot of things that can be done now early on to make sure these clinical features don't get bad. So early diagnosis is very, very important in being able to help out patients who have this. Referral triggers are usually metabolic complications onset. So once you have severe metabolic complications, that's causing the diagnosis to happen, but you're already quite progressed, and then it's very difficult to control some of the metabolic features at that point. there is a significant quality of life impact. So the patient's mental health, self-image, there are a lot of these concerns that need to be affected. So we need early diagnosis, we need help with psychologists, social workers to be able to navigate the quality of life impact on these. And the barriers to metreleptin therapy too. I'm just starting it again. As I said, it might be covered in another lunch and learn, but metreleptin is out there. But there's limited experience in physicians who have used it, so they are not quite aware of it as much as they should. And then there's access restrictions. So making referral to specialists usually helps with it, and early diagnosis is the primary target there. And that is it for me. Thank you.
Great, thank you so much. I have several questions, but I just wanted to know, Jennifer and Antonio, if you have any questions, you can ask them, or you can write them in the chat.
Happy to answer.
Okay, I can start. My first question is, I think, something that comes up a lot in our Facebook group and when we are discussing the issues with parents. If you suspect that your child have some type of lipodystrophy, and your clinician, physician send you to a bunch of tests, but nothing comes up, how can you bring up the lipodystrophy diagnosis?
So that is a very good question. A lot of diagnosis for syndromes are not as straightforward. I do, being an endocrinologist, I think I diagnose and come across a lot of diagnoses that should not be presented to patients unless you're sure about it. It is okay to discuss differentials. If there's somebody coming in and you think you might potentially have progeria versus lipodystrophy versus a syndrome I really don't know, I think it's best to say that these are potential things I'm thinking about. I'm going to look into labs and imaging to help narrow down what I think it is. And it's always okay, I feel, to call the experts and discuss with them. So I get calls from physicians all over the country running these things by me. That I have somebody like this. A lot of them can come and see us on our research side. So we do have research funding and they fly in so that we can actually examine them, do the phenotyping. Because it's not only just sending a panel of genetic tests that can help us diagnose. As we saw, there is a genetic aspect, there's also an acquired aspect. So the onset helps a lot. If you have somebody since birth, then honestly, sending the genetic panel helps diagnose majority of the CGLs. But we still have quite a few of them that are undiagnosed too. We all have a panel of patients that do not fit in the four subcategories, and we still need to learn a lot more. If it is acquired, then it is very different anyways, because there is no genetic testing, there's no one targeted. So I think it's more phenotyping with somebody who has done it to put it in the picture. So I wish there was a clear cookie cutter diagnosis, this is it to do it. We do have pretty good pathways now outlined in the guidelines. So Dr. Brown and there were at least I think 15 of us who had come up with guidelines almost a decade ago now, which has a flow chart that can help think and then again in the end call us. The images that I was showing in it, that's a very decent picture too. And we have actually made a very nice poster that shows if this is what the fat loss looking like, then you probably have it, then call us. But yeah, if you don't have a specific genetic reason and targeted testing, it's very difficult to say you have this syndrome unless it's been seen done by an actual expert who's seen hundreds of these, which is very few in the country.
Yeah, I think that one of the problems are that many clinicians do not know about lipodystrophy. It's not something that you're being taught at medical school, or you might hear it
Absolutely.
once in your life and that's it. You never
Absolutely.
see a patient if you're not going specifically to lipodystrophy. So
And
is
that's
it
why I wanted to do this talk, just to tell that the challenges out there because it's so rare that it's difficult to teach. I'm trying to do my part. I have added a section of lipodystrophy in our big pediatric endocrinology book. So we all have these Bibles that everybody reads, right? And the pediatric endocrinology book is called Sperling, which didn't even have anything on lipodystrophy. So their newest edition is going to come out, I think next year, maybe longer. I don't know how long it takes for newer editions to come, but it has lipodystrophy now. I wrote that chapter. There are a few other places I've written chapters, so I'm hoping I can spread a little more awareness in people who are reading these books.
Yeah, amazing, amazing. Oh, I think we have a question in the chat. I was lucky that a doctor, when I was 15, took a look at me and knew to test me. Jennifer said it.
Yeah, no,
Um,
no. And I feel there is a lot of diagnosis still happening, but yes, there are definitely missed ones too.
yeah. One other problem is that I don't know about the pediatric cases, but in adults, clinicians do not do physical examination. Is it something that happens in the pediatric patients as
So
well?
I feel in pediatrics, it happens more after adolescence. Um, because the kids get very shy, they're always embarrassed, they don't want to let other people examine them. So I think when they're young, the pediatricians are very good at examining. So congenital ones should definitely be picked up early. But the familial partial is a little tricky because I have a little struggle too. I try to convince my patients I need to examine you, but they reach that phase of emotional maturity where they are shy in doing it. And I'm sure you've seen nowadays there are all these jackets in which even the thumbs are covered, right? Like they just covered themselves. So I've had kids who have had xanthomas and they would refuse to show me unless I actually forced them to, because the xanthomas were hiding everywhere and they just kept them covered inside, not wanting to show.
Yeah. Can you explain what xanthomas are? Because I don't think that everyone knows.
Yes, so xanthomas are the skin spots that can appear if you have very high triglycerides. So the thing with high triglyceride is it likes to deposit in organs like liver and pancreas, but it can also go under the skin and you can actually see them in the eye vessels too. So the examination findings are making sure you check the skins and especially extensors. So knees, elbows, and these parts are where it's going to start popping up first. And if you actually can dim the lights and look in the back of the eye, you can start seeing the blood vessels in the back of the eye turn whitish with the high triglyceride in the blood. So these are some examination features that can help pick, but you have to have triglycerides over 2000. So as I said, the normal value is usually under 150. But I have several kids with lipodystrophy who get very high triglycerides. One of my congenital has gone up to 12,000 triglycerides as well. So anything over two, you can pick up these things in examination.
Yeah. With the acquired type, especially with the autoimmune, once you know you have this autoimmune disease that can cause lipodystrophy, it's not 100% that you will have lipodystrophy at the end, but our parents can take actionable steps to prevent or even to surveillance
So
this.
I don't think we can make it part of surveillance till we actually know the prevalence and ratio of autoimmune causing lipodystrophy. And that has been an absolute disconnect because autoimmune diseases are very, very prevalent. And I think only a small fraction of them have lipodystrophy. But we don't know the fraction because I think there is a lot of lipodystrophy out there that's not getting diagnosed. So if there is a percentage, if we even knew that, 10% of every autoimmune disease would potentially have, then we should go and spread awareness in them. But we don't even know if it is 10 or 1 or point 0.1. It could be anything at this point because we don't have that data. That's why I think it's important to get that.
Yeah, definitely. Um, One more question. If a parent think their child have lipodystrophy and they talk to the pediatric physician and they don't think they have lipodystrophy, can they directly contact one of you guys as experts, or do you need the clinician physician to contact you?
So the clinician physicians always contact us. I am constantly, regularly talking with physicians everywhere. If they ever have a question, I am not sure about patients directly reaching out to me. I feel if they reach out to you guys and you reach out to me, that might be easier because being part of a university employee, I cannot see them outside university. Yeah, I've never thought of that because I only see patients at UT and children's.
Yeah.
So I'm not sure
We
how it works outside.
We can definitely help. So if you have a case where you need to contact an expert of lipodystrophy, we can definitely help you with it. I asked before because sometimes patients, not so much in the pediatric world, but more of the adult world,
Mhm.
they say that they mentioned lipodystrophy to their physician and they just like said no, it's not possible or it's not the
Yeah.
right diagnosis, and they really think like in the absence of other diagnoses that they have lipodystrophy. So we try to contact with the adult endocrinologist,
Mhm.
but I guess we will have cases of pediatric
No, I
patients as
agree. I
well.
agree completely. I mean, in all honesty, the best way is just to tell them, can you call Dr. Patni and discuss it? And we give you permission. And that works. But if the physician's completely saying no, then I think reaching out via you guys might be the better way. Because with pediatrics, the rules are again strict too, and I can only see kids as part of UT and children's. I cannot independently see them.
Yeah, yeah. Yeah, we can definitely help. You can contact Lipodystrophy United on our social media and
Yeah.
our info email info@lipodystrophyunited.org. We can definitely help with that. Yeah, any advice to newly diagnosed parents?
No, the only advice to newly advanced parents is that we have therapies now. We have metreleptin that can help reverse a lot of metabolic features. We still, unfortunately, don't have anything to reverse the subacute fat loss. But early diagnosis helps a lot with understanding the disease, understanding there's so many people out there, finding your peers, finding your group cohorts to navigate it together.
Do you have any support groups at the university or as part of your treatment?
Not yet. I feel most of my patients are coming from everywhere. I have people driving from so many places, so it's not a cohort of people living close by that they regularly meet. So pediatric patients definitely, yes, they are. There is no actual support group yet, but I do share Lipodystrophy United with them when they come and see me.
Yeah. Perfect. Jennifer or Antonio, if you have any more questions, now is the time. I think I covered everything. If not, then thank you so much. I think it was a very important talk. Jennifer, did you want to say something?
No, I was just unmuting myself so I could say
Oh,
goodbye.
okay. Thank you so much, Dr. Patni. You are a part of our scientific advisory board, so if you have any other questions, you can always reach out and we will ask. And if you have a kid with lipodystrophy or you are suspecting of lipodystrophy, we can always contact her and help you. So thank you so much. And this will be on our website and our YouTube channel. And hopefully we will see you for another talk soon.
Thank you so much for having me.
Thanks.
All right,
Bye.
thank you.
I
Bye.